Posterior cranial vault distraction osteogenesis, PVDO. A multidisciplinary team is critical to these patients and this case. PVDO is most often used for syndromic craniosynostosis. In patients with abnormal cranial and facial anatomy, airway management is critical. Patient positioning in order to protect the globes from pressure is paramount. Here, the eyes are positioned and then checked with a mirror. The bicoronal incision is marked. Old scars and shunt position are noted. In our institution, a standardized timeout is used. Sterile prep and hemostatic infiltration are performed. Blood loss mitigation is important at every step of the case. The skin incision is opened with a knife and cautery is used to deepen it. Reoperative cases are typically bloodier because a subgaleal plane cannot be used. For this case, preoperative 3D planning was performed. The 3D printed marking guide can be seen here. A large posterior craniotomy is marked with methylene blue. The craniotomy is performed. On our team, this is done using very small burr holes. The posterior keel can be the most challenging area. It is critical to ensure a complete osteotomy in order to avoid hardware failure. .3D printed models from the planning process can be used to verify distractor positioning and then distractor plates on the back table. Barrel stave osteotomies are made posteriorly to minimize step-off created by distraction and to add additional intracranial volume. The plan is reviewed for distractor positioning. 2 low lateral distractors are placed. The distractor arm is brought through the scalp through a stab incision. The distractors are placed with self-drilling, self-tapping screws of 3 to 4 millimeters in length. It is critical to protect the dura with a retractor. There are unpublished reports of dural injury leading to pseudomeningocele from this procedure period. These screws must be placed with extreme care because the patients often have thin and fragile bone. Bone thickness improves dramatically after distraction expansion. Once placed, the distractors are tested and the ratchet is activated to avoid reversal during the distraction process. The scalp is closed under acceptable tension with resorbable sutures. Distraction commences on postoperative day number 1 at 1 millimeter per day. Weekly or biweekly x-rays are used along with frequent follow-up visits. After placement of distractors, patients spend 1 night in the ICU and are discharged home on postoperative day number 2 or 3. The published literature on distraction notes a relatively high complication rate and thus close follow-up is required. In our institution, we have not had any instances of cranial distractor hardware failure. At the end of the distraction process, a consolidation period of 8 to 10 weeks is used before removal. This is limited incision surgery with a brief overnight hospital stay.